athletic trainer. I've been at OHSU for now, oh gosh, 13 years. I've been in practice for over 25 years, and I've always been a sports physical therapist. So this really is my thing. I have seen probably hundreds of ACL patients throughout my career. Things have changed quite a bit over the decade and a half that I've been practicing, and hopefully I can share some of my insights with you about where we are, where we may be going, things that we maybe need to do better with. So with that, we'll get us started. Let's see if I can. Okay, all right, good. So a little overview of what we're going to be talking about. Current data for ACL reconstruction. I'm going to talk a bit about the foundation. So as much as, yes, this talk is geared towards a return to sports, I think that there are some things that we as physical therapists could be better with the earlier phases and the foundational things that we need to do in order to get our patients ready for returning to sports and even sports testing. And if by chance we have some time, then I'll go through a case study also. So ACLs, it's a common injury. I mean, from an overall standpoint, this is just US statistics, but about 3% of amateur and 15% of elite athletes injure their ACLs. In the US, I know that we in the US, compared to the rest of the world, we do have a tendency of doing reconstructions more often and more quickly than other places in the world. But with the high number that we see, one of the good things is that we have a lot of time to practice what we're learning, and certainly there's a lot of research on ACL reconstructions because of just the sheer volume that we see. There's, of course, a lot of elite athletes from around the world that have injured their ACLs and have been able to get back to playing. So Virgil, a world-renowned soccer player from the States, American football. Tom Brady is considered kind of the greatest of all-time quarterbacks. He injured his ACL, and I think he won 2 or 3 Super Bowls after he came back from his injury. This is Lindsey Vonn. She was an alpine downhill skier on the Olympic women's team for the US. She actually had 2 ACL reconstructions and was able to come back and win a bronze. So it's obvious that you can have this injury and still get back to elite level activity. And that's kind of what our patients expect. So a study found that 88% of people that injure their ACLs kind of expect to get back to the level of sports that they were used to playing. However, the statistics show that we're not actually that great at getting patients back to the level of competitive sports that they previously played. So a research article found that as low as 55% return to the prior level of competitive sports. And from a PT standpoint, that's not a passing grade. We need to get better. From a re-injury standpoint, statistics show that up to 22% of patients will re-rupture the reconstructed ACL within about 5 years, and up to 24% will re-rupture the opposite side within 5 years. So, it's very interesting for the amount of research that we have, the sheer volume of patients that have had this injury and that we've rehabilitated. We're still really kind of missing the mark. There's a lot of things that we could do to improve the care that we're giving our athletes. As I mentioned, I've been practicing for 20 plus years, and it's just interesting to see the pendulum swing. When I first started practicing, we were really restrictive. Patients were in the hospital for maybe a couple of days. They were in these braces that really limited range of motion. We probably weren't putting weight on the leg for up to a couple of weeks. And an injury to your ACL, 20 plus years ago was a career ending injury. You were not going to come back from that. And then over time, I would say about the mid 90s, at least here in the United States, there was a group out of Indianapolis that challenged the status quo and actually allowed very aggressive return to activity. They almost allowed the patients to progress as tolerated. They didn't set standards for when you could do something and when you couldn't. They just allowed the patients to kind of indicate, to the therapist how their knee was feeling, and if they felt okay, they continued to advance the level of exercises. And in this, I think it's swung quite a bit in the opposite direction, where some were returning to full sports activity within 12 weeks. At the time, we had patients that would doctor shop and would try and find a surgeon that would be doing the aggressive return to sport plan. And if they found a doctor that wouldn't do that, they'd switch and go somewhere else. Unfortunately, what we learned from that is that they end up re-injuring at a much higher rate. So we're kind of settling back from these extremes of really restrictive and then really, really aggressive to kind of like a middle zone. And yet still, like as the data showed, it's fascinating to me that we still are seeing such a high injury rate and such a high or a low return to sports rate. So often then I think, well, what are we missing? What things as physical therapists could we be doing better to train, prepare our patients for when they're returning to sport? How are we testing patients to determine if they are ready? And these are the questions that I have in my mind. I think we've got a little background with the group.
Yeah.
Is there a way to mute?
Serena Corinne, can you please mute?
Awesome. Thank you.
Yeah.
All right. So because of the statistics and because of our not great score as far as being able to get our patients back to the level of activity that they want to, I did want to cover some of what I call the foundations of ACL rehab and the things that I think that are really important, the things that data and research have pointed to of being an important part of the overall protocol, and maybe some things that we as physical therapists may not be implementing, even though the research points to something that we really should. So I tell patients that the return to sport, it begins day one after surgery. So if we are not doing things well early in the rehab process, it is going to make the ability to get back to sports so much more difficult. So we want to instill that everything that they're doing in the beginning is all along that road to getting them back to where they want to be. So we're going to touch on some of these early foundational things, and it may seem simplistic and simple, but they are really important. So the first really is full knee extension. I think like if I have a patient that is not obtaining full knee extension within the first 2 weeks, I'm getting concerned. The most common thing that we run into when people can't obtain full extension is because of a lack of that end range extension. We know that their quad is not firing in a normal way, and we know that more often than not they're going to end up having anterior knee pain that also slows down the progression of their strengthening. So early knee extension, early passive knee extension, and then obviously active knee extension is really key. Again, my criteria is if we're not getting it within the first 2 weeks, I'm kind of playing the heavy card that I'm really focusing the patient on making sure that they're doing their home exercise program in regards to working on their extension. NMES. So back in the day, I think NMES used to be used for basically muscle reintegration.
Excuse
So,
Daniel
yep.
yeah
Yeah.
สมิติเวชศรีนครินทร์ครับปิดไมค์ได้ไหมครับ
Please say that again.
Oh, she was telling Serena Krin to please mute themselves.
Oh, okay. So I can pause a little if that would be helpful.
Well, actually, I think I can mute everyone and then unmute you. So
Okay.
let me just.
I had a fan just go on right on over me, so I hope that the fan noise is not bothersome either. So, but so NMES is something that back in the day we used to only use if the patient was not able to fire their quad. If they had a good quad set, then we didn't feel like they needed NMES because we thought of it only as a motor learning modality. And research actually shows that everyone following an ACL reconstruction would benefit from NMES for the first 6 weeks after surgery. Even if you have just a small amount of swelling, just even 3 cc's of swelling, that amount of swelling can inhibit muscle activation, and that inhibition of muscle activation, again, over the course of weeks, ends up resulting in a loss of muscle strength. So there's very few things that we have A-level evidence in physical therapy for doing. And when it comes to NMES after a postoperative knee surgery, we have A-level evidence to utilize it. So our best practice guideline is for the protocols that we utilize is that every patient gets an NMES unit for home. I think one of the other things regarding the use of NMES is that it's important to make sure that you're doing a high enough intensity. I know that patients often are not, it can be really quite uncomfortable, and turning it up high enough in order to get a real muscle contraction can take some getting used to. But unless you're using the intensity high enough to create a muscle contraction, then we're not utilizing it to the extent, it's almost like we're underdosing the modality. So it's important not only to use from a frequency standpoint, but most important to make sure that we're using the higher intensity also. Blood flow restriction. So blood flow restriction, that might be a modality that you have available to you. I have to say that, this is something that has been in our practice now for, maybe the last 8 years or so. And I have to say that if someone told me 20 years ago that you could put a blood pressure cuff thing around your thigh and reduce the blood flow, that somehow that would result in muscle strengthening, I would think that it would be science fiction. But it actually is something that not only is effective, but it's been really researched as being, I think, something that is foundational when we have a need that has obviously tissue healing restrictions. We're limited in being able to do some loading, and without being able to load, then we're not going to be able to strengthen the muscles. And blood flow restriction really bridges that gap. We don't have to use load, but we still get the muscle response that we would otherwise with load. Let's see here. I'm just taking a quick look at the chat here. What is the importance of ACL reconstruction? Could you suggest home exercise program, prescription, treatments like NMS? How long time should be for exercise and closed chain? Yeah, we will get to things such as that. So, and I will say, like almost all of the patients that we see, we are seeing maybe 1 time a week. The goal really is to give them exercises to do on their own. Early on, we're doing things such as quad sets and straight leg raises, but within a few weeks, we are starting to do some closed chain exercises, and I'll kind of get into some of those specifics in just a bit here. So open chain knee extension exercise. This is again is another one of those foundational exercises that I think early on there was research that may have pointed to open chain knee extension being stressful on the ACL. And so for decades, physical therapists were reluctant to do this exercise because they were fearful that there would be extra strain on the ACL. And what we've actually learned is that's really not the case. Even doing a loaded straight or leg extension will have the same amount of ACL strain as actually just walking and going up and down stairs. So even though there's a lot of research now that points to the safety of doing open chain knee extensions, many physical therapists still are really wary of doing so. And as such, we're not utilizing this tool. And with closed chain exercises, so closed chain exercises are ones that your feet are on the ground. They're like mini squats, step ups, things of that nature. Open chain is where your foot is not on the ground. We can initiate closed chain early. However, closed chain does not isolate the quad. And so your brain is really smart. If you are strong in your glutes, your brain is going to use your glutes more to do the squat than a muscle that's weaker like your quads. And so one of the challenges with people or therapists that utilize a lot of closed chain exercises is that the quad does not get that isolated strengthening, and therefore they don't reach the level of quad strength that they need in order to safely return to sports. So beginning at about 4 weeks, we start to do some isolated leg extensions. We have blood flow restrictions, so we're able to use that motion of a leg extension without necessarily putting on a lot of load. But as time goes on, we're adding load, and usually at least by 8 weeks, we're getting rid of the blood flow and we're only using the load of the leg extension machine. So this, again, I think is a foundational thing that physical therapists have been very slow to incorporate into the early phases of rehab. And certainly we have to be mindful of anterior knee pain. It is not unusual that people that have weakness in their quad and or swelling can end up having symptoms around the patellofemoral joint, but we want to monitor that. And we can adjust the amount of resistance, we can adjust the range of motion in order to minimize anterior knee pain. But probably when people come to OHSU that have not been doing well after their ACL reconstruction, probably the number one thing that we find is that they haven't been doing isolated leg extensions and they haven't been loading with isolated leg extensions. Hip strengthening and biomechanical training. So knee valgus and rotational stresses is the enemy of the knee. So anybody that will fall into this valgus position is going to be at a risk for an ACL injury. Oftentimes the lateral hip adductors are a component of the knee valgus. And so early and often training hip abduction. Certainly you can do sideline hip abduction, but we do band related exercises also in standing, and training to make sure that then while we're doing squatting, while we're doing our hip exercises, that we're also making sure that from a form standpoint, they're not falling into this knee valgus position. So it's not just the amount of exercise or the type of exercise, but the quality of the movement that they're doing also. So now we're going to get into a handful of specifics. So one of the other newer aspects of ACL rehab is dual task training. And so it's not, like proprioceptive or balance exercises have been frequently used in ACL protocols. However, we need balance and we need quick muscle activation when we're not necessarily thinking of it. And so one of the challenges is to make sure that we are challenging balance in a way that has the patient not necessarily just thinking about balance. So I am going to try and play this short video. I hope that it works. So here's an individual there on a BOSU soft surface doing a single leg balance, and then they are also playing like a little toss with themselves. So,
want to level up your balance training? Tired of doing this static activity? Add a multitask activity to increase the challenge. The client performs one leg stands on a BOSU ball while tossing and catching the ball. This forces the client to shift their attention and makes the activity more challenging. Numerous studies have shown that adding a multitask activity increases the effectiveness of balance training. You will have to closely guard your client. Look in the description for more information.
So obviously this is not an exercise that we would do immediately. We would do some static balance on a flat surface first, but this is a level of progression that we need to incorporate again so that we're challenging our patients in more real world activity. So this next video is an example of a hip strengthening exercise. They have a band around their legs and they're doing lateral or sideways motion. But again, we're combining a cognitive now activity at the same time that we're doing the strengthening. So the individual is to toss the ball up when the therapist gives an odd number and to bounce the ball when there's an even number. So they're having to react to and think of what's happening at the same time they're doing the strengthening exercise.
1, 8, 12, 14, 13, 9, 11, 2, 4.
Very good. All righty. All right. This is another, again, we're getting into little higher level activities. This is not something that we would be doing in the early phases. But again, we're trying to talk about dual task training, which is something that is a little bit newer in our ACL rehab. We have these things, they're called blaze pods. So you can see the lights on the floor here, and they turn different colors. And the thing, light went out. There we go. The thing about some of the exercises that we have our patients do is that we give them a direction and they know exactly what to do and what's going to happen. And real life is not like that. Most people are involved in sports that have them reacting to situations. And so we want to incorporate exercises that involve them reacting to situations. And so this particular exercise has the client doing a lunge, and every time that the blue shows up, that's the direction that he lunges to. So, and this might have some funny music, so I apologize for that. Alrighty. So again, that's another component of what we call dual task training, something that I think that we've not been doing as part of our normal rehab, and maybe as a piece that we could be incorporating into our rehab programs. Alrighty. Okay, so talking about the phases of rehab. So I see a little bit in the chat about kind of phases and when we do different things. So early, the first couple 3 weeks phases, we're really working on those foundational things. We're looking at increasing the extension range of motion, activating the quads using those NMES, and I use stationary bike early on, helping to reduce swelling. Then as we're getting into weeks 3 to 12 is really when we're starting to ramp up the amount of load. And certainly, again, we can, from a progression standpoint, you're going from double leg kind of closed chain to single leg closed chain to weighted type of closed chain like leg presses. Same thing, we go from using BFR with leg extensions to no BFR and weighted leg extensions. So this progression in this phase 2 is really an increase in the amount of strengthening that we're doing. We still want to overload the muscles. So I think that that's another key component. We have to manage swelling. We have to manage soreness. We have to make sure that we're not irritating the joint. We don't want to create any patellofemoral issues, but it is really important that we're challenging the muscles. So if it comes to your quad, your hamstring, your hip, it really should be the level of strengthening to overload the muscle. Then, of course, we're doing balance-related exercises and going from more static to then more dynamic, and then like what we kind of like showed some of the more dual task. So, and I'll look at some of the questions and maybe answer some of them as we get close to the end. Some good questions about knee extension and the amount of knee extension range of motion. I will say it can be physician specific. Our physicians have guided us to try and reestablish what their normal is. So if their surgical side, if their non-surgical side allows a little bit of hyperextension, we are going to allow a little bit of hyperextension. Otherwise, for that athlete, they might feel like one leg is a little shorter than the other. So we're certainly not going to force somebody into hyperextension that otherwise their opposite side doesn't have any hyperextension, but we're not so nervous about it if that's their norm. So we're going to get now into a little bit of the phases. So we've established this base of strength. For the first 12 weeks, we've been working on their strength, their proprioception, obviously their range of motion, again, trying to control swelling, control soreness as we're going through this process. From a protocol standpoint, at about that 12-week mark, again, a little bit depending upon the kind of graph that is done, we start to look at whether or not someone is ready to run and jump. And it's not just time, it really is criteria. So as much as I think that's one of the other challenges that I see that therapists have is they're using a time frame in order to determine when is it time for somebody to begin running rather than time plus criteria. And for us, we have the criteria before you move from that phase 2 of strengthening to then incorporating some running, jumping, cutting. We need to make sure that they're strong enough. So usually at around 12 weeks is when we're starting to look at then doing some actual testing. So the first test that we really do is isokinetic testing, and we're looking at strengthening and seeing if they are from a limb symmetry. So the isokinetic test that we do 60, 180, and 300 degrees per second, and we're looking at concentric quad and concentric hamstring strength, and we're comparing the non-surgical side to the surgical side. Our goal is if you're within 75% of your uninjured side, then we allow to initiate some walking and jogging and some light plyometric activity. If they're not ready, if they are at that about 12 weeks and we do the test and they have not demonstrated enough strength, then we continue to work on strength. But it's not just time, it is the criteria of hitting that bar in order to progress them to the next phase. So this is just an example. I will say that one of the things that can be challenging is that we don't have great research on what's the best way to progress these activities. What's the best way once someone has achieved a certain amount of baseline strength that we should progress running or sprinting or jumping or cutting? We have to use kind of like our physiological, expertise in both slowly progressing as well as watching the signs and symptoms of whether or not their knee is tolerating the activity before we advance them. So this is just this is just one example of a progression that involves not only kind of an increasing in the amount of running, but as well as starting to do a little bit of curving. So you're not just doing straight line. So not that this particular protocol has been specifically researched, but that does give you a little bit of a guideline to follow. So from a jumping or plyometric or cutting standpoint, you know, how do we usually progress our clients? We generally go from doing double leg exercises to single leg exercises. So double, and we have a shuttle. I have a video of it in a bit here where you're able to lie down so you don't have body weight. So we start doing double leg jumping without body weight to get our patients used to that impact. Then we'll go to single leg jumping on that shuttle, then to weight bearing double leg, then we'll do weight bearing. Generally speaking, it's less stressful on the knee when you're jumping up than when you're jumping down. So when we start to do some vertical jumping, we actually jump up first and then start to work on then jumping down, or both jumping up and down. And then we start adding some twisting. So that's kind of how we progress some of our plyometrics or jumping activities. From a running cutting standpoint, we're first trying to do working on running speed in a straight line. Then we'll start to do in multi-directional activities. As well as kind of like a quick stop and turning of direction. And again, I have some video examples of that. And then kind of like I mentioned, this idea of pre-planned activity versus reactive activity. So real world is really reactive. So as much as our exercises often are kind of pre-planned, we do want to get creative in putting some reactive type of exercises in. So let me give you some examples of what we were talking about there. So this is our shuttle. And this is just starting to jump.
You want to push off with your.
So again, we are
and then land with the
initiating non-weight bearing double leg.
Knees, hips, ankles, flex.
And the goal really with jumping is to make sure that we're landing softly so that the knees, the hips, and the ankles are all flexed as we're landing. And that quality, kind of like I mentioned earlier with that knee valgus, as people are progressing with their jumping, we really want to make sure that we're controlling for that knee valgus also. So now this is an example of doing now a weight bearing, and we're going to be doing some jumping up vertical, and that's more of the emphasis than the jumping down. Just a little too good. So again, going from a non-weight bearing shuttle to now weight bearing, again, 2 leg. Now we're going to do weight bearing 2 leg up and twist, and then a land. So adding a little bit of a rotational component in addition to the vertical. So just some examples of kind of how we can progress when we're doing some more plyometric jumping activity. And all of this was double leg. So you can, as they are demonstrating good form, again, they're not falling into knee valgus. If they're demonstrating good form, we can start to progress in similar ways into single leg. All right, so this is an example of a cutting, but with a pre-planned. He knows exactly where he's going to go. So it's not a reactive exercise. It's just a pre-planned cutting drill.
Nice.
Go. And with that, I usually like to have the surgical side be the one that they're planting and then pushing off of. This next one is more of a reactive exercise. So they're still doing cutting, but they're having to react to this pole and where it's falling.
stick, stick, stick leg. Stick, stick, stick leg. My blicky.
So again, I think that this type of exercise where you're doing a more reactive is one of the types of exercises that we haven't been as consistent with utilizing in our programs. As we're going through the sports training and doing more, I guess, functional type of training, it's important to watch for swelling and soreness. If you have swelling and soreness, it's an indication that we're progressing things too quickly. You know, this phase of rehab is really long. So if by chance at 12 weeks, someone passes that isokinetic test with that 75% goal, you know, we're doing these types of progression of training from month 3 until month 9. So it's important not to try and go too fast. Sometimes athletes are really excited and they want to go, and you have to kind of slow them down. Some are a little hesitant and you need to coax them along. Rest and recovery is important, but you really want to make sure that you're doing this in a slow and progressive manner. Then, of course, there's the, well, what kind of sport are they wanting to get back to doing? And that's where you have to know a little bit about the sport. You know, are they a soccer player and obviously long endurance, but involves quick changes, cutting? Are they more of a vertical athlete like a basketball player? We've worked with linemen, and so they are explosive forward and a little bit of lateral, but they're not really doing much from an endurance standpoint. So if you have athletic trainers that you can work with or coaches that you can connect to get some of the sport specific drills that they do just in practice, and they can incorporate that into their rehab. So again, like I mentioned, from like this 3-month to this 9-month period of time, we're still doing the foundational things. We're still doing quads and hamstrings and hip strengthening. We're still doing proprioceptive, dual task training types of exercises. Sometimes our patients are kind of bored with those things, but those are our foundational things. If they started at 75% to 12 weeks, we need them to be 90% by the time that they are ready for full return to sport at 9 months. But we have a good 6 months period of time to progressively increase the level of intensity when it comes to the running, jumping, and sport-specific activities. I'll also put in here, communicate with coaches, and if we have time to do my little case study, this is a lesson that I have learned in the past, that it really is important to be communicating with coaches as to where the athlete is at and what they're allowed to do. We want them to be involved in their teams to the extent that they can. That's actually psychologically really good for them to be connected with their team, but we also want to have clear indication as to what they're allowed to do and what they're not allowed to do. And this is one of the ways that we can kind of structure communication. So we've gone through the rehab process. They're maybe getting to that 8-9 months-ish mark, and we're ready to see whether or not they can graduate from physical therapy and if they are able to return to full sports activity. Unfortunately, there's not one gold standard for return to sports testing. It really is kind of a cluster of tests that we use to determine if somebody is ready to go. And there's a lot of good and I think valid tests that are out there. The team that we have here at OHSU has done quite a bit of research as to what tests are the best ones that have the best evidence to back them up, as well as from a time standpoint to make sure that the amount of testing that we do is not so time intensive for the amount of time that we have with the athletes. So these 4 testing components are what we utilize at OHSU, the noise jumping test. Again, quad and hamstring strength testing. We do a balance test. We actually specifically use the Y balance. And then the subjective, it's a measure, it's a test that the athlete takes that that gives an idea of where they're at psychologically as far as their readiness to return to sport. And this is one that we have started to utilize even earlier on in the rehab protocol. So we might start to do this and give this test to the athlete, you know, maybe at 4 months. So they've started to do some running, started to do some jumping, and we want to get a sense as to how confident they're feeling and where they're at. Because certainly if we need to work on confidence, that's another component to the rehab that we need to be mindful of. So this is the noise jump test. If you're not familiar with it, it's a 4 series of jump testing. It is basically a measurement of quantity. You're measuring your surgical side versus your non-surgical side. And so the first test is simply you're doing a single jump for distance, and you do it on the non-surgical side and then on the surgical side. The second one is a crossover hop test where you're crossing over a line. So you do 3 jumps, but you're starting on your right side, you're going to first cross over onto the left, then cross back on over onto the right, and then the third jump back, cross on over onto the left. And you measure again the distance that you did on your surgical side and then compare that to the non-surgical side. The triple hop for distance is kind of the same thing, you're just not crossing over. So it's 3 big hops in a straight line, again, measuring that for distance. And then the fourth one is, this is a 6-meter line, and we time how long it takes them to go from the beginning to the end of that 6 meters. From a research standpoint, those that are more considered, that the athlete themselves actually considers themselves normal, they were within 90% symmetry of the opposite side. I think one of the things that, again, when we talk about missing pieces or things that may be related to why our injury rate is still higher than we would like, or why patients are not getting back to the same level of activity as they used to before. We don't have very good measures of quality. So obviously, if somebody's landing like you see with the knee valgus on this right side, that quality of control is not as good. And yet they could still have a measurement that's equal to the other side. So I think that that's going to be kind of the future of ACLs, is how can we measure the quality of the movement, specifically kind of the lateral and rotational component that right now we don't really have good tests for. So isokinetic testing, again, we mentioned that we did this at about 12 weeks, looking for that 75% symmetry. By the time that we get to the 9-month mark, we are looking for 90%. We do the testing at 60, 180, and 300 degrees per second. We do concentric, so it's quad, you're pushing up, and hamstring, you're pulling in. If you don't have an isokinetic machine, then handheld dynamometry, you know, is a potential option. Obviously, it's an isometric. Obviously, it's only at one point in the range of motion, but getting some numbers associated is better than no numbers. Oops. Okay, this Y balance. Oops, hang on a second. So the Y balance test, this is, so the C-best or Y balance is basically a measure of balance and kind of rotational control. So in this video, the leg that we are measuring is actually the stationary one. They're going to be moving, reaching anteriorly, laterally, and medially. There's actually numbers on the tube. You can do a similar thing. The C-best is a similar type of exercise or a test that you're basically having tape on the ground, and then you're measuring how far they're able to reach in each diagonal pattern. And again, you're looking for within 90% symmetry, left side versus right side. So this here, you're reaching out as far as you can. You have to be able to come back to neutral. And then again, we would measure that distance on each side. And then we would compare it to the non-surgical side. There was a study that actually found this was kind of like a pre-injury study where they did the Y balance with healthy basketball players, and they used that to determine what the risk of injury was. And for those that had a difference of more than 4 centimeters when they did the forward or anterior direction, those that had a greater than 4 centimeter difference left versus right had a 2.5 time increased risk of injury. So I found that study kind of interesting. And this was the questionnaire that I mentioned. It just gives some insight as to whether or not someone is psychologically feeling that they're confident and ready to return to sport. So one of the things that I did not get into all the details of is the different types of grafts. And obviously the different grafts can impact how quickly you are progressing. I think one of the things that I have found is that when patients have allografts, they do so well that it's actually really hard to slow them down. We know that the graft takes longer to incorporate, and so actually a return to sport is closer to 12 months instead of 9 months. But the hard thing is to slow the athlete down because they feel like they are ready to go. A hamstring graft, you're just not able to do really loaded hamstrings for at least 12 weeks. So we push out the isokinetic testing or their strength testing until about that 16-week mark. Again, we'll test them before we determine whether or not they're ready for plyometrics. So just a little summary as far as return to sport. So again, it is not just time, it is criteria. So for our allografts, we're looking at 12 months, but our other graft types, we're looking at least 9 months before their graft is really ready for that athletic type of activity. But it's not just time, it's whether or not their tissues are ready. And so we want to utilize the testing to see what their balance and control is with the Y balance. We want that to be at least 90, if not 95%. 90% for the noise jump test, again, looking left versus right. We want to be within 90% for our quad testing. Certainly, we also test the hamstrings, but most of the evidence is pointing to the quad as the one that needs to be symmetrical, and then whether or not the patient is actually psychologically ready to go. So I have a little case study here. Let me quickly go through this, and then I want to make sure that I'm getting to the question. So we always learn our most, I think, from the patients that maybe didn't do as well. And so I wanted to kind of share this case study with you as an example. He was a 16-year-old basketball player. His name was Ed. He was very enthusiastic, very focused, highly motivated to get back to playing basketball. He had a non-contact injury. He had surgery within 2 weeks. That's kind of our system, get him into surgery as quickly as possible. He had a hamstring tendon graft. And so as such, we had to, of course, delay some of the hamstring exercises. But for the first 0 to 2 weeks, I saw like some questions about modalities. Yes, we use ice, we use the Game Ready in order to help control swelling. That's probably from a modality standpoint, other than the NMES and BFR is what we utilize. We don't use many other modalities. It really is kind of an exercise-based program. So the first 2 weeks, like I mentioned, we are getting that knee straight. Knee extension was the key thing. He was able to get his full knee extension within a couple of weeks. He was able to get off of his crutches within a couple of weeks. He was very consistent at using his NMES and doing some stationary bike. Within 6 weeks, we were utilizing blood flow restriction, including some leg extension that was not loaded. We began some closed chain exercises such as mini squats, a little bit of wall sits. We started to do some static balance exercises, and towards the end of 6 weeks, started to do a little bit of dual task. I would have him like stand on one leg and like brush his teeth when he was at home as his dual task activity. He did very well from week 6 to week 12. Again, we were doing a lot with this quad because he had a hamstring tendon graft. We did start to do a little blood flow restriction without any load, with knee flexion beginning at about week 8. Because of the hamstring tendon graft, we decided to wait a little bit until week 16 to do his isokinetic testing. He passed. He was very confident, and this is where I think from a learning standpoint for me, at week 16 when we started to do some walking, a walk jog program and started to do some plyometrics, he was all in. He was very excited to begin these activities. And then from week 20 to week 9 months, we progressed. We increased his strength. We worked on his plyometrics and cutting, kind of similar exercises to what we showed earlier. At about 8 months, so we have an insurance situation where sometimes we start running out of visits. And so we were running out of visits at 8 months. So we did his whole battery of tests at 8 months and he passed. So even though he was not at that 9-month mark, we had to discharge him, but I told him you are not ready to go until 9 months. Again, he was always really, really confident, and always kind of had the, oh no, I can do it kind of mentality. Unfortunately, I found out afterwards that at around that 6-week time when he had passed his isokinetic testing, he actually started to play one-on-one basketball. And 18 months after returning to full sport, he re-injured his ACL. And I think the learning for me, there's like certainly the quantitative things of making sure that they're doing the exercises correctly and so forth. And I think the learning for me was definitely knowing that his confidence level was so high, I should have slowed his exercises from a sports standpoint down a little bit, and really communicate with coaches as to what he was allowed to do, because he was doing far more things when he was not with us in rehab than his knee was really ready for, and I think that greatly contributed to his re-injury. So with that, I am going to kind of take a quick look at the chat here for questions. Can you suggest about cardiovascular capacity with return to sport? You know, that's a good question. I think it can be a little bit hard because there's different types of athletes. And so you want to be including the conditioning level all along. So if I have an athlete that is like a soccer player, that I'm starting with their sport specific activities, maybe say by month 4, I am going to incorporate a more conditioning with running and or maybe the elliptical and or biking into their program more so maybe than I would say like a football linebacker. Hydrotherapy, again, I think I mentioned the kind of modalities that we use. We'll use the Game Ready ice as a way of controlling the swelling. We don't have in-house any type of an ability to do aquatics, and so that's not part of our normal routine. I'm not saying that it's bad, but it's just not something that we have as an option. From the isokinetic test, the question was 60 degrees per second. We actually test at 60, 180, and 300 degrees per second. It's been really hard to find a lot of research that shows which degrees per second is the best. And hopefully, I think the very first question was a lot about phases of rehab, and I hope I kind of touched on that kind of throughout the talk. So any other additional questions? I want to be respectful of time. I know that we are getting close to our hour, and my light keeps going off. If you have any additional questions, please feel free to put it in the chat.
Anyone have any questions? Ask one question.
Awesome. Well, if there's not any specific questions, I will be sharing.
That is, can you suggest, let me read. Can you suggest us about cardiovascular capacity for return to sport?
Yeah, like cardiovascular capacity really is, we don't do any specific testing for cardiovascular capacity as a measurement of whether or not somebody is ready to return to sport. We will certainly incorporate the types of cardiovascular training into their sport-specific training. Again, a soccer player is going to be different than an American football player or a volleyball player. And so we'll incorporate that into their return to sport phase. So in the last, so beginning, 12, 16 weeks until 9 months, we'll incorporate that into their routine. But we don't test the cardiovascular capacity as a component of our return to sport. Isokinetics at 12 weeks, which kind of dynamometer do you use? So we use the Biodex. I've used the Kincom and Cybex in the past. And anti-shear, we don't use anti-shear. So back in the day, I did use anti-shear, and that was because we had this idea that loaded open chain resisted leg extension would put stress on the ACL. And studies now have shown that that's not the case. So there's no need for anti-shear. So we never actually used anti-shear at all. Very good question. Do you use isokinetic machine for training as well as that? Yeah, we do. So it depends upon the individual, and it depends upon how frequently they are able to come in. Again, a lot of the patients that we see are limited by the number of visits that they have. And so once we get to, say, week 16 or so, I want to make sure that they have their program that they can do on their own, because I'm just not seeing them all that frequently. There are people that don't have access to a leg extension machine. And I think the best way of fatiguing the quad is to do a series of isokinetics. And so sometimes I do incorporate that into the training. But it really, for us, I know it might be kind of like the strange thing, we really have to use the amount of visits that we get to kind of decide where we have our attention. But if I had the ability to do isokinetic training, I would certainly do it fairly frequently. The one thing that, at least to be mindful of, it depends upon how you have your isokinetic system set up. The testing that we do is concentric and concentric. So you're pushing up for your quad and you're pulling in for your hamstring, and that does not test the eccentric phase. And that's where just a typical weight machine, you're going to get both concentric and eccentric load. Back when I first started to practice the Kincom that I mentioned, that is another isokinetic type of machine. It was very easy to test both concentric and eccentric. And of all the modes that the athlete had a harder time to pass, it was the quad eccentrically. And I sometimes wonder if, again, like we talk about the missing piece and what are we missing, that still we're saying patients are ready to get back to sport and yet they still can re-injure themselves. And I sometimes wonder if it's that lack of eccentric load that we're not actually testing, and if that's where what the missing piece is. So how much pain scale do you allow each time with a program, especially in the earlier stage? Well, certainly there's post-operative pain, and if you had surgery, there is going to be pain. I think some of it is kind of normalizing that hurt does not mean harm. That is a message that they hear from the surgeon. That is a message that they'll hear from us, that you're going to have some pain because you just had surgery. But there's a difference between, say, pain around the patella that I don't want if I'm doing a quad activation exercise versus, okay, I know your knee is swollen. And so when we start to do range of motion, it's actually at first going to hurt. But the more that we do it, actually, the better it feels. And I usually just kind of like prove that to them. But from a soreness overall, I don't want people to come in. I want that soreness to go back to baseline within 24 hours. So any kind of soreness that they might have felt from the PT session, the within 24 hours, it's kind of back to baseline. So I hope that makes sense. Can you give me more information on open chain quadriceps exercise? Really, the open chain quad exercise is that leg extension. That is your foot can't be in contact with the ground. And so it's a simple exercise, but that really is the one that does it. It isolates the quad. So, and what is good load? Eventually, so certainly early on, again, I'm using more BFR with lower load. Eventually, I want to be able to get up to a good, 80% of 1 rep max. So from how do I determine that? I want to be able to have the client do 2 to 3 sets of maybe 6 to 8 repetitions. So a little heavier on the load. If they're doing sets of 15 and 20, then the load isn't heavy enough. So I'm somewhere around, the 8 for me is kind of the sweet spot. If I can get 2 to 3 sets of 8 repetitions, and that last set, those last few repetitions are like, wow, I'm not sure if I can do anymore, then that's the sweet spot of the amount of load that I want to be working on, especially once we're getting past that about 12 weeks. Before return to sport, do you recommend the patient to do a reconditioning program? And I guess part of the reconditioning program is the guidance that I'm giving as far as the sports specific activities. So I might be working with the coach in that type of a capacity. Again, I'm giving guidelines as far as what you're not allowed to do yet. And if it fits into those guidelines, then they can be maybe doing some of the drills that they would normally do in practice. They're just not doing them at the full speed. They're not going one-on-one against a competitor, that type of a thing. So my hope is that, from month 3 to month 9, when hopefully they're ready for discharge, that actually is part of their reconditioning program. Okay, I think that's all as far as the questions that I have. And sorry if I went long. I appreciate everybody's time. I know it's an early morning for you all. And again, I will make sure to get these slides on over to Connie, and she can send them out to you.
Thank you very much for the very insightful and detailed lecture. And we reached the time quickly. Thank you very much once again, Janelle.
All righty, thank you. Have a great day.
Thank you, Janelle. Amazing.
Oh, thank you. Appreciate it. Have a great
Yes.
night, Connie.
Yeah,
Thank
you
you.
too. And good day to all of the people in Thailand.
Yes. Enjoy your day.
Sawadika.
Bye.
สวัสดีค่ะคอนนี่
Bye.
สวัสดีค่ะ Take care คอนนี่
Thank you.
Enjoy dinner.
Yes, and
Thank you.
we need to bring Janelle to Thailand. She was supposed to come when COVID hit.
Yeah,
So maybe this next year.
that'd be fun.
Good job.
Awesome. All right. Have a great day. Thank you.
Thank you. Sawadika.
Take care.